Assalamu alaikum everyone. My name is Amreen and my roll number is PP1650024. My group number is 27. I am from the morning food professional. It's the assignment of pharmacy practice and my topic is Amiodaron induced pulmonary toxicity. Let's start with the introduction. Amiodaron is an anti-arrhythmic agent which belongs to class 3, which is a potassium channel blocker, and it is used to treat supraventricular and ventricular arrhythmias. First of all, what is arrhythmia? Arrhythmia is the irregular rhythm of the heart, that heart beats too fast or too slow. What is supraventricular arrhythmia? It is commonly known as tachycardia, whereas ventricular arrhythmia, the arrhythmia which arises from the bottom ventricular of the heart. Amiodaron drug contain iodine and it may accumulate into the several organs of the body like lungs, liver, skin, eyes, and it causes a lots of side effect in our body. One of these adverse event is that it causes amiodaron pulmonary toxicity, and which is our main topic. Now come to the clinical pharmacology. Amiodaron is taken orally and it can be taken intravenously, but in serious condition. If you taken it orally, so amiodaron is absorbed slowly and incompletely. Although its bioavailability may be enhanced if it is taken with the food, and if we take it with the grapefruit, then its bioavailability is more enhanced. An important property of amiodaron is that it is highly lipid soluble. It tends to accumulate extensively in adipose tissue and highly perfused organs such as liver, lungs, and spleen. The large volume of distribution results in a delayed onset of action when taken orally and a long elimination half-life 14 days to 120 days. Amiodaron is metabolized by the liver through the cytochrome P450 enzyme, and it is converted from amiodaron to desethyl amiodaron, that is DEA. It is excreted via biliary system, and a very little amount of amiodaron and its metabolized is found in the urine. If we are talking about the amiodaron toxicity, so we should keep in mind that the toxicity cannot be removed from the body through the dialysis, either if it is amiodaron or it is its metabolites, that is GEA. Now come to the clinical use. As we previously discussed that amiodaron is an anti-arrhythmic agent. So first use of amiodaron is what? It is an anti-arrhythmic agent. Now the second use, previously it was used as anti-anginal agent because of its vasodilation properties. It has multiple well-described biochemical and electrophysiological effects. Pathology of AIPT. During chronic therapy, amiodaron and its metabolite desethyl amiodaron DEAM accumulate extensively in the tissue of the lungs as well as liver, skin, thyroid, and eye. At therapeutic serum concentration, both agents are toxic to lung cell, and this toxicity is likely to increase by the 100-fold and 500-fold concentration ratio of amiodaron and DEA metabolites respectively in cells. Lysosome leads to blockage of the turnover of endogenous phospholipids, which then also accumulate in the lungs and lead to the characteristic finding of foamy lipid-laden macrophages in BAL or lungs tissue of patient receiving chronic amiodaron therapy. You can see the normal lung histology and the lungs having amiodaron induced pulmonary toxicity. There is foamy macrophages appearance in the lungs. Efflux is going on into the tissues and cell, but it's too slow, and significant amount of both compound have been found in the lungs of patient on autopsy 1 year after treatment cessation. Complications. What complications we can face? Pulmonary toxicity usually manifests as an acute or subacute pneumonitis, typically with diffuse infiltrates on chest, X-ray, and high resolution computed tomography. Other more localized form of pulmonary toxicity may occur, including pleural disease, migratory infiltrates, and single or multiple nodules. Now come to the case study. RW, a 55-year-old man admitted with a 5-day history of fatigue, exertional dyspnea and tachypnea, reports that his symptoms have progressively worsened to the point at which he can no longer walk with his dog around the neighborhood without feeling out of breath. He denies experiencing coughing or chest pain. He has medical history of recurrent ventricular tachycardia and a 10-year history of hypertension, controlled with benazepril. Physical examination reveals a tachypneic, tired-looking man with no sign of congestive failure evident on physical examination. Diffuse inspiratory crackle are audible on lungs excultation. His blood pressure and temperature are unremarkable. A chest radiograph shows patch interstitial infiltrates and HRCT reveals diffuse ground glass opacities. BAL reveals the appearance of foamy alveolar macrophages and lamellated inclusion bodies. All laboratory tests are within normal limits except for an elevated ESR. His medications on admission include Amiodaron 400 mg every day, initiated 12 months ago, and previous, and benazepril 40 mg every day. Soap notes. Subjective age 55 years, gender male, history fatigue, exertional dyspnea and tachypnea, recurrent ventricular tachycardia and 10-year history of hypertension. Objective physical examination reveals a tachypnea, diffuse inspiratory crackle audible on lungs excultation, patchy interstitial infiltrate, and HRCT reveals diffuse ground glass opacities on chest radiograph, foamy alveolar macrophages and lamellated inclusion bodies on BAL, elevated ESR, medications Amiodaron 400 mg every day and benazepril 400 mg every day. Here elevated ESR indicates the infection and the dose of Amiodaron indicate the patient is having ventricular arrhythmia. Assessment. The diagnosis of APT in this patient is consistent by the presence of free foamy intraalveolar macrophages and patchy interstitial infiltrates. Besides, patient's pulmonary complaints, radiographic findings, elevated ESR and BAL results all are supportive in the diagnosis of APT. Plan. Corticosteroid should be initiated to hasten recovery and minimize the likelihood of lungs fibrosis. The sole withdrawal of amiodaron may not improve symptoms or imaging. Corticosteroid therapy should be continued for extended period to avoid recurrence of symptoms during tapering. The reasonable estimate of duration of corticosteroid therapy is 6 months to 1 year. Suggested regimen is 0.75 to 1 mg per kg of oral prednisolone or 40 to 60 mg daily. Note: as we are given corticosteroid to the patient, so we have to keep in mind that we have to monitor the patient because corticosteroids have a lot of adverse effect including opportunistic infection, and patient should also be monitored so the chances of recurrence for APT can be reduced. Clinical symptoms may resolve in 2 to 4 weeks. However, chest radiographic finding usually clear over 3 months or more. Thank you.